I always get given this task every year, and it's to talk about all of endovascular surgery for abdominal aortic aneurysms that went over the 1 year. So we're not going to go through the technical details of everything, but I'm going to show you kind of some of the technology and what's around today. I have no relevant financial disclosures to this talk. These are the current guidelines. You're going to see patients who present to your office with a variety of different medical conditions. These are the guidelines for AAAs. The USPSTF says men 65 to 75 with any history of smoking, if they smoke 1 cigarette. The SVS guidelines expanded this a little bit more to say, hey, it's not just men who get it, women also get it. So 65 to 75 people who've smoked, men or women. And then they expanded these guidelines to include patients who have first-degree relatives. And if any of your patients in your office meet this, send them for at least 1-time screening ultrasound of the abdominal aorta. This is why it's important. This is a retrospective review that they looked at 55,000 patients who underwent some sort of endovascular aneurysm repair or open repair, patients who are already deemed to meet criteria for repair. And when they look back at the USPSTF guidelines, the SVS guidelines, and the expanded guidelines, you can see it misses a lot of patients. Only 33% and 33 and 32% of patients would have met guidelines for any kind of repair screening guidelines. This is to say, our screening guidelines are not perfect, and if you have any kind of family history or any inkling of it, definitely have some suspicion that these patients may have a AAA. Suprarenal fixation is the oldest tried and true kind of stent graft that's been out there. These are made of Dacron. There's stents on the outside, and there's these suprarenal fixation struts that are meant to go above the renal arteries that kind of anchor and secure your stent graft so it doesn't migrate distally. And you've heard these kind of companies before, Medtronic and Cook, those are the giants that have been around. The Terumo Trio is another one that has entered kind of the market and doing a good job. And these are standard kind of infrarenal devices that have been around for a long time. Infrarenal fixation, meaning no suprarenal fixation stents that going above the actual renal arteries. This has also been around for a while. Gore excluder is the one that you will think about. And I don't know if your practices do EVAR, but this is, if you have fellows who are going to deploy it, this is the best one because this is the only one with a, oh no, we deployed in the wrong location, recapture and reposition it. This is slightly different. It's made out of PTFE and not Dacron, but it's another one that has a really good market share and does a really good job. There's another one that's been around for a while, which is polymer sealing. This is huge suprarenal fixation struts, and then you have a polymer ring, almost like the glue, almost like a rubber glue that you fill into the space. The nice thing about this is, and this was very popular in the beginning before people were facile with large bore access, is because this is still, to date, the smallest EVAR graft that's on the market. This goes through a 14 French sheet. 14 French sheet, I see you guys shrugging your shoulders. Yeah, we could do 14 French sheet, that sounds fine. They're no longer the 20 French sheets that you guys are accustomed to for EVARs in the past. And large amount of that is because this whole stent graft in the beginning doesn't have any stents, they just have these polymer rings. So before you inflate them, they're pretty low profile and it's been around. Not as popular because a little bit challenging to repair if there's any kind of leak or type 1 endo leak above it. So it's not the most popular graft, but good for you to know. One failed concept about polymers, and this came from the same company, was this idea of Nelix, and you may hear about patients who've had a Nelix, and these were basically covered stents, like your Viabonds, that had a bag on the outside that you can fill with a polymer that was supposed to fill the aneurysm sac. Great in concept. It existed for a while, and then it went down really poorly because up to 33% of those patients had some sort of failure of the graft. So this is no longer on the market, but you may still see patients going around with this stent graft inside them. This one you may see because this also gets used when you guys are treating aortoiliac occlusive disease, which is the unibody AFX, and structurally a little bit different. It's a stent graft that's designed to sit on the aortic bifurcation, so if the patient has extensive aortoiliac disease, this is a decent option to a CRAB or kissing iliac stents because then you can preserve the ability to go up and over to the contralateral side. Unlike the other stent grafts, the fabric is on the outside and the stent is on the inside, which means that there's no fabric bunching inside the lumen, which can often cause a smaller lumen and cause it to thrombose, which is a really good feature of this. And probably a couple times a year, we're doing this for aortoiliac occlusive disease in addition to AAA repair. Now, a couple trends I want to talk about is Decreasing trend in reintervention and readmission after endovascular aneurysm repair. About 5 years ago, there was a lot of literature that came out that the long-term outcomes of open repair are superior to endovascular aneurysm repair. I will probably challenge that a bit. If you look at the outcomes of endovascular repair back in 2010 versus 2019, you have significantly less one-year secondary reintervention rate, much less 90-day readmission rate. And a large part of this is that the grafts that were available to you back in 2010, a lot of them have either been modified or have been taken off the market because they haven't been working properly. So the new generation of devices that we have currently are working pretty well, and they're pretty durable for our AAA patients. With that, with endovascular aneurysm repair becoming more common and more durable, it does mean that the open abdominal aortic aneurysm repair experience is going down across the entire country, and that's to be expected. And when you looked at this, in this study, they had 49,000 EVARs versus 11,000 open aneurysm repairs that were done in the same setting. And when you looked at the proportion of centers that are meeting the SVS aortic guidelines to say you have the ability as a hospital to do these procedures, the number of hospitals that actually met the EVAR requirement went up by 67% versus the open repair went from 32 to 16%. And this is largely because open aortic aneurysm repair was being less than 10 times a year in a lot of these local facilities. And a lot of the hospitals that you work at, because endovascular has made significant advancements, it definitely ends up becoming the first line of standard for many treatment centers. It's a concerning fact that we talk about in our vascular surgery societies on a regular basis. Some accepted approaches that are not universal. We almost always try to go percutaneous. This has been around since 2018. Large bore percutaneous access, through your experience in TAVRs, through our experience in AAAs, has gotten pretty facile, and we're able to do large bore accesses for these patients, and they do better than an open surgical cut down. They can end up with a full EVAR through small little groin punctures. It's the accepted approach for ruptured aneurysms as well. Now, if you look at ruptured aneurysms versus ruptured endovascular repair versus ruptured open repair, significantly different outcomes. 5 days stay for EVAR versus 10 days for open, 18% 30-day mortality versus 32, 35% adverse event versus 68% major adverse event rate for ruptured open repair patients. And then 1 year survival, which is what it's all about, much better for patients who are undergoing ruptured endovascular aneurysm repair. And a large element of this is that you don't have the huge fluid shifts that go with open surgery. You can also do the entire ruptured endovascular aneurysm repair with patients under local anesthesia. And if you think about the times where patients are crashing, it's during induction of general anesthesia. When you looked at population-based long-term outcomes of open repair versus endovascular aneurysm repair for ruptured aneurysms, it's about the same. It's another study that's showing you that all-cause mortality and major adverse cardiac events are significantly better for EVAR versus open repair, with no difference in later day outcomes at 30 days, 5 years, and 5 to 10 years. So I think as the technology is improving, this notion that open is more durable and endo is less durable, it is changing more and more. There is a caveat, and this has been known since 2019. You take devices and use them in anatomy that it was not meant for, meaning you're using the devices off instructions for use or IFU, they're going to do worse. In those kind of cases, for off IFU cases, if you're pushing the envelope with the endovascular devices, they actually do worse than the open repair because they weren't meant to be in that kind of anatomy. So it is something to keep in mind. So with that, what are the things that pushes a EVAR off of IFU, and there are continued challenges for this. Neck angulation, it still ends up being one of the biggest ones. And there were some grafts that have been looked at for like 90-degree turns just below the infrarenal devices. This is the AorFix device, which we don't have access to in the US, and they have a conformable excluder that's meant to design to go into 90-degree necks, but still, this is a continued challenge. And if it's a very tortuous neck at the anatomy, it's off IFU and the patients don't do as well. Interestingly enough, I do think that the Alto polymer ring that I was telling you about before actually takes these bends pretty well. So in my practice, whenever we have a really angulated infrarenal neck, you can get a seal with this kind of polymer. I know it looks kind of jacked up as a angiogram where it looks like there's a significant narrowing, but in terms of a seal for your AAA, this is a pretty significant turn that it's able to take. Another continued challenge, we used to cheat. These are meant initially to be landed in aneurysms that have a good 15 millimeter neck below the renal arteries. But because we said endovascular is arguably easier and maybe less, better outcomes in open repair, people started pushing the envelope for shorter, fatter necks. So this aortic seal, this area of normal aorta, before it dilates into an aneurysm, people push the envelope for short and large necks, and in those kind of scenarios, the patients didn't do as well. So nowadays, the mantra has gone towards building up higher with fenestrated stent grafts, where you're actually going up to normal aorta so that you know that you have a good seal that's durable. There are some other ideas about trying to maximize your infrarenal seal by putting in an endo stapler. And this one, unlike the other ones, say you only need a 7 millimeter neck. But in general, if the neck below the renal arteries are unhealthy, the mantra is to go up and find normal, healthy aorta that you're going to seal into so you can have some durable results. This has kind of gone out of favor where people used to do a lot of snorkeling, where put these kind of covered stents next to your aortic stent graft in an attempt to go up higher. But the downside of something like this is that you do have gutter leaks since you're putting multiple pieces next to each other, and you won't have a watertight seal. So even though this had existed, people have gone away from this a bit. And then now the preponderance of chimney and snorkels are going down a lot more. The one that I showed you before with the stent coming up, those are called chimneys or snorkels. They are falling by the wayside because compared to the fenestrated stent grafts or physician-modified stent grafts, where you're able to put in dedicated holes into the stent grafts, the outcomes are a lot worse for stroke and major cardiac events. So people are moving away from chimney and snorkel. We modify these devices when it doesn't fit the patient's anatomy. We'll take a stent graft, we'll burn holes into it, suture our own rings or our own branches to fit the patient's anatomy, and this has now become a lot more universal across the country, and there's a lot more experience with this in the beginning. It still makes no sense that we have to use eye cautery and burn holes in our own stent grafts, but that's what we have available because commercially available devices are not as frequent. This being said, the Gore company came out with this Tambi graft last year, and I just heard a fascinating statistic. It became available to market, not just in research, just a little over a year ago. And within 1 year's time, across the country, 1,000 of these had been implanted, which shows you that a lot of kind of physicians have been waiting for some sort of device like this to treat a lot of their patients. But now you do have an off-the-shelf device that you can use for thoracoabdominal and infrarenal aneurysms if the neck is really short. The last kind of thing I'll touch upon is that with endo leaks, and you may see this company here in their exhibit hall, there's thought that chasing an endo leak after it occurs is very challenging, so try to stop the endo leak before it happens. So the impede shaped polymer is this coil that has a little plug that's attached to it that expands once it's put inside the body, and it's meant to fill up space so that blood can't actually fill up into the space. Interesting in concept, a little bit expensive. There are some physicians who are using this to treat their patients across the country. This is the last thing I want to end on, and because there has been a significant shift from open to endovascular repair that you have seen across the country, it's meant that it has affected the vascular surgery trainees' volume for both of these things. So if you look at the trends in annual open AAA volumes for vascular trainees compared to annual national volumes in the endovascular era, what you're seeing is that open AAA repair had an 84.7% decrease, over the course from 2006 to 2017. That's a pretty alarming statistic for us as a specialty to actually talk about. It's the same thing for aortoiliac femoral bypass and total aortic repair, significant decrease in everything. So one of the things that we're talking about as a society is how do we maintain training levels so that they have the ability to do these cases when they're attendings. And that's all I have for you guys. Thank you for your attention.